All right. So, for those who don't know me, my name's Edward. I will be your host for the quarter for Design at Large. And the theme that we're going to be having this quarter is kind of COVID broadly construed, really around this idea of how to be, how to stay safe, and I like to say sane during a time of COVID-19. And our first speaker today is going to be Ursula Myers, who's coming to us from oh, the there's many affiliations, but the one that she said is the Medical University of South Carolina, MUSC. And actually, we went over this. She has a whole slide on herself. So instead of me going over it, Ursula said she would like to go over herself. So I'm going to hand the floor off to Ursula, and I'm very excited about her talk.
I am excited too. This is a really cool idea. I appreciate you reaching out and getting this set up. Yeah, I know it's always awkward to introduce someone while they're staring at you. So I just, a lot of times just have a default slide to talk a little bit about me and my dogs, obviously. But so I'm a psychologist by training. I actually did my graduate work at UCSD, so that's kind of why I thought I got approached at first. I was at the joint doctoral program there with UCSD and SDSU. Now I'm affiliated with both the Medical University of South Carolina, MUSC, as well as the Ralph H. Johnson VA Medical Center in Charleston, South Carolina, along with other acronyms and titles that we all love to give each other. But I'm going to really talk about, what does telemental healthcare look like? What did it look like before COVID? Because we have a lot of data and support of kind of what we've done before then, during COVID of these last 6-7 months. And then hopefully someday what a post-COVID world could look like if we get there. So like I was saying, I did my PhD out there in San Diego, and then I matched in Charleston for internship, and that's where I stayed. Though I am not actually in Charleston anymore. I am attached to Charleston, but I physically live in Phoenix. So last October is when I moved out here and became virtual. So I timed it pretty nicely. I have been able to spend this time figuring out what telework looks like before the rest of the world had to. So I think that's made life a smidge easier during this time. But even before then, once I started in Charleston, I had been doing clinical services through telehealth, and 100% of my patient caseload was telehealth since 2018. So this is not a new world for me. So really my research focus is on how do we use mixed methodologies, so both quantitative work that we all get trained on in our PhD programs, along with qualitative work, so we can understand the user impact and how users actually touch the designs that we're trying to study, to really figure out how we can do kind of more with the things that are working and less of the things that aren't working, specifically related to telemental healthcare. I have two researchers that you might see walking behind me sometimes. Brain is on the left, he's the older beagle. Obi's the younger one on the right. So I've given them chewy sticks and they hopefully should be distracted, but in case you see them, they are line items on these projects. So just a little bit of an idea of kind of what I'm going to chat about. I want to give you guys just a little bit of information about what the VA telehealth looks like in particular, because I've been in the VA since 2010. This all, all these acronyms sound like real words to me. All of this stuff kind of I just take for granted. So I'm hoping to make sure I don't leave kind of anyone behind as I'm chatting about it. Talk about our rapid expansion over the last couple of years pre-pandemic, that we were already really focused on this, kind of what COVID-19 has looked like and how it's impacted us, and then kind of where we're going to be hopefully going next, and figuring out how we can sustain really good care being provided via telemental health. So you have some idea of kind of what the VA kind of structure looks like. So when we talk about the VA, there's even kind of overall VA, and then underneath there's the healthcare side of it, and there's the benefit side of it. A lot of times people are really mad about the benefit side, and so we get lumped in there, but I'm going to focus on the healthcare side of the VA, which is really large. So that kind of picture on the top left there, that's the La Jolla VA. It did not look like that when I was there just 5 years ago, and I think it probably looks even different now with we didn't have parking garages when I was there, let's just say that. But we have medical centers that are kind of our large hospitals where we do outpatient care, inpatient care, all of that type of stuff. We have outpatient clinics that are kind of typically focused in this hub and spoke model, where you have a big medical center, but then Mission Valley has a CBOC, Chula Vista has a CBOC, Oceanside has a CBOC. So to kind of prevent on kind of veterans having to drive all the way to the main facility, they can go to these outpatient clinics. Then we also have different kind of residential services. We have vet centers, which are readjustment counseling centers specifically, mobile vet centers. So when we talk about the VA, it is a really large network that spreads across the country. And we have been doing telehealth a very long time. So starting in the 60s to the 80s, that's really when it all kind of started. The very first kind of telemedicine that existed was between the Medford VA and Mass Gen. They were really close to each other, but still the fact, I mean, this picture is amazing, right? Like that we have the technology to be able to kind of provide care at remote sites is not new. It feels like it's this brand new thing that we're all starting to do during COVID, but we have been doing this for quite a while. So kind of before this year, we had a lot of different aspects of telehealth in the VA. So at home, we would do kind of home monitoring, like glucose levels, blood pressure. We have kind of these different devices that veterans can kind of use their device once, get it set up, and we'll get the data sent direct to us. We have VA Video Connect, which I'm going to talk most of today about. That's actually the video sessions that we do. We do a lot from clinic to clinic. So if we have specialty care providers at a main hospital, we would have kind of the provider there who would then provide services to someone who will drive to the outpatient clinic down in Chula Vista to be able to talk to the specialist that's up in La Jolla. In the hospital itself, we will do tele ICU and stroke. I don't know all the details on that because that is definitely not my specialty, but within, we can kind of basically make sure we're getting specialty providers access to patients when they need it, where they need it. So within facilities, we're doing that kind of connection. We're able to kind of create these regional centers. So there are like teledermatology centers or telemental health centers or telesleep centers where, you know, unsurprisingly, a lot of specialty care providers like to live in really beautiful parts of the country, like in San Diego, but not all of our veterans live there, right? So if we have this cluster of specialists, we can kind of then focus out and provide some of these services to veterans that are kind of scattered in that particular region. But we can also do it nationally, right? So the great thing about being in the VA and a federal institution is our licenses work across state lines. We're licensed at the federal facility, which enables a lot of this care to happen. So we have lots of consultation, being able to talk to, you know, someone who specializes in a, you know, very particular kind of tumor. You can get a radiologist who's going to understand that and read those, you know, from Charleston to San Diego to Honolulu, you know, across, we can do all of those things. So this is really not brand new stuff for the VA. We have been doing this for quite a while. So in particular, because I'm a psychologist, I'm going to talk about telemental healthcare because that's actually the stuff that I understand. And even within mental health care, the way I kind of think about it is there's really a continuum of therapy and a continuum of care. So we do have medication management, prescribing, you know, antidepressants, sleep meds, those type of things. We do some group. And then within talk therapy, you know, on one side of the spectrum, we have kind of general supportive care where someone, you know, listens to your current stressors, try and help you kind of cope with what's going on. You might chat with them once a month. You kind of feel better in the moment, but it's not specifically targeted towards anything. I kind of think about it like getting a massage where you felt better in the moment, but you aren't like, whew, never need one of those again. And then on that other spectrum is really this evidence-based psychotherapy. And this is the model that we've really been moving towards over the past 15 years or so. And I think about it much more similarly to like physical therapy, basically. You have specific kind of symptoms or stressors that you want to work on. We're going to spend 12 to 15 sessions kind of purposefully going after them, addressing them. You're going to have homework exercises that go along with it, with the idea that you're kind of go in, hit it hard. We'll give you some skills, help you reduce some stress. And then you're going to be going out and living your life and doing things that are kind of really more important to you than coming and sitting in my office for an hour every week. So the VA has really worked hard on disseminating evidence-based psychotherapy. So psychotherapies that we have good clinical evidence to show that they're effective in treating the disorder that they're targeted for. and disseminating them across the country. So we have fantastic treatments for depression, anxiety, PTSD, substance use disorders, couples issues, family issues, and severe mental illness as well. So we always have kind of all of these type of mental health care options that exist, and it's mandated. Every VA facility is going to be able to provide these type of services. And so that's part of what telehealth can help with. If we have someone who really needs to address their severe PTSD, but they live kind of an hour outside of Hinesville, Georgia, then we can still make sure that they're getting seen with a specialty provider who's trained in the therapy that's going to be the most effective for them. We have a ton of literature to support it. I'm pretty sure I peeped that Leslie was on this call. Leslie has done at least half of these projects on here. So the literature supporting the effectiveness of telehealth to clinic, telehealth to home, the satisfaction with telehealth, the therapeutic alliance between the provider and the patient or veteran, treatment dropout. We have been studying this for quite a while. So we really, this is, when I say we didn't just start doing this, we really didn't just start doing this. This is something that starting from basically the mid 2000s on has really been a huge focus of what's happening here. And I'm so thankful that Leslie has been doing all of this work, because it has enabled us to roll this out across the country. So pre-COVID, some of the reasons for veterans doing telemental health care were kind of like I was saying, right? Getting access to the specialty care trained providers. Regardless of where you live, you can live in the middle of nowhere and we can still get you connected. If we, in addition to kind of location, being able to increase engagement in care and treatment completion, if we aren't requiring you to kind of drive all the way in for some of this care, we can do these appointments on your lunch break or maybe right after work. We can keep you wrapped in because, like I was saying before, 12 to 15 weekly sessions that last an hour, you have to have the best healthcare on the planet to be able to take off, or the best kind of benefits to be able to take off that much work and not be able to kind of be severely impacted by that. So it really, there were quite a few reasons why we were really focused on pushing this, and access in particular is a big kind of focus for the VA, that we want to make sure that veterans are getting the care that they need when they want it and where they want it. So like I was mentioning a little bit before, we have this kind of traditional hub and spoke model. That's how the VAs were designed, with the main hospital in the middle, then these outpatient clinics. And so what would typically happen, so we talk about that veteran who, let's say they live 45 minutes from the Chula Vista CBOC. So they leave their house, they drive, and depending on what, is that the 8th? I'm blending freeways, but I think, they jump on the freeway, let's say there's a little bit of traffic, they finally get to the clinic, they park, they check in, they sit, they come in, they have their hour-long session with their therapist who's physically located at the La Jolla VA. Then they check out, they get their car, and they drive home. So we've met them out much closer to where they live, right? Like they're not having to drive and take the entire day off of work to get all the way to La Jolla. But this is still probably a 5-hour commitment every week. And so it was a great place to start. We have lots of literature to support how well this is working, but we knew this is not where we wanted to stop. The goal was really to be able to reach out there. So I wanted to highlight this particular story and highlight the year. So this video is from 2016. So this is about a veteran. His name obviously is not actually John, but he was someone who enlisted in the Army post 9/11 when he was living in New York. He did 6 deployments as an Army Ranger to Iraq and Afghanistan. So I'm guessing everyone knows that was not very pleasant. Before he worked with, Dr. Burks is the provider who he worked with, who was expertly trained by Dr. Moreland. So before he started working with Anna, he had really sporadic attendance. He was really, often late to session, had a tough time making it in. He's someone who was diagnosed with post-traumatic stress disorder. GAD is generalized anxiety disorder, so he had that on top of PTSD, along with substance abuse, which is really common with PTSD, and depression. In addition to that, he's working full-time at a farm super early. So he was trying to address his anxiety using cognitive behavioral therapy for anxiety, which is one of those evidence-based psychotherapies. So let me show a little bit of what this looked like for him, maybe. Mini player. Just one, there we go, full screen. Okay, does that look okay on your guys' end?
You
You get cheap?
Live and work on a farm.
The YouTube did not show.
It is not showing? Okay, let me try and reload it. So I am seeing sheep on my end. And I want you guys to be seeing sheep too. Can you see the YouTube here?
Nope.
Oh,
You're just sharing your presentation.
oh, but I had told it I wanted the full screen. Let's try this again. Because hearing sheep is one thing, seeing sheep is another. Is this looking better?
Works for me.
Okay, so let me go back to full screen mode so you get the full sheep experience. All
I live and work on a farm. I've been there for a little over 4 years. I deployed to Afghanistan 3 times. I deployed to Iraq twice, and then a training mission in Africa. When I got out and I was like, whew, I'm out. I'm going to go live. And then you don't realize you're leaving everything that you know and everything that you are proud of. And then the minute you start slipping, all of that goodness kind of goes away. And then you do find yourself completely alone. And when you're alone, it just gets darker. It does take an amount of courage to come in and just kind of admit, okay, I'm not in control anymore.
John and I first started working together several years ago, and I originally started seeing him face to face. As a psychologist, my training background has been specifically in treating PTSD over telemental health. Home-based telemental health really adds another layer to the services to veterans where we're coming to them rather than us relying on them to come to us.
In the beginning, people were not very familiar with what telemental health was, and we did a lot of the seminal work that's published right now to prove that seeing patients in person is just as effective as telemental health. We've taken this beyond just telemental health into a clinic now to telemental health into someone's home.
It was difficult for him to leave the farm, just different responsibilities tied to the farm that it was really difficult for him to leave.
That's where the home-based therapy I thought was actually perfect. I'm an hour and a half away, easy. So getting in the car and driving all the way down here, thinking about what you're going to say, thinking all this, before you even get in the office, you can't sort of decompress first. I was hesitant because I wasn't sure who is all going to be involved in this thing, and I really like the personal contact. But the minute you're in it and she's sitting right on the screen, I'm like, oh, you're on my kitchen table.
The goals are to basically deliver the best practice that we have in the same way that you would in a face-to-face visit.
It worked great for me because I knew when it was coming up, I can get a few things done and then actually get settled in, be comfortable without any sort of distraction interfering, and log on and just like someone coming to your house. I mean, it's pretty awesome and helpful. For me on the farm, it was just that much easier because that's where my work was anyway. You're dealing with guys that are warriors. They can pretty much walk into anything from a fire to a firefight. But to walk in and talk about things is like a different fight. I mean, there's guys that they really need it. They just can't get there.
So now I'm going to go back to there. And so, let's see. And now everyone sees my slides. Fabulous, awesome. So, we started that, that kind of, beautiful version of what it could look like from 2016, right? Like we had been selling people on this for a while. Starting in 2018 is when we've gone through different iterations of what we're gonna call it and brand it. The VA always has to create its own system because we're the government. But what we use is called VA Video Connect. So basically what it's been since 2018, and really before, that's just when we started calling it that, is that our veterans kind of log into the session. I call in, we have our hour-long appointment. If someone needs a tablet, so this is a picture here in the middle, if you are, you don't have the resources and you don't have Wi-Fi at home, you don't have a smartphone, which, I mean, I will say that, it's dramatically decreased the amount of people who don't have some access to it, but that absolutely still exists. Then we're able to issue a VA tablet that is both Wi-Fi and cellular capable, and we're able to do our appointments that way. So this picture of the tablet set up in a car, I 100% have veterans that I am seeing in their car, before they head home from work at the end of the day. And this is, a way that I'm able to really kind of meet their needs and kind of get them the treatment that they have been looking for. So before COVID-19, we had been dramatically increasing. So as part of the Mission Act, there was kind of a stipulation within there called VA Anywhere to Anywhere, where we were really trying to increase the access and basically capability of providers to offer telemental healthcare. Because it started with kind of pockets of researchers who then were working with their own clinics on site. And then the idea was we were going to keep expanding this and doing it nationally. So through last year, if you look kind of on the left, you can see kind of all of our encounters, and that's basically an appointment. Every encounter is an appointment that was being done through telehealth. So telehealth overall was dramatically increasing. So this bar chart actually doesn't show that we, under the telehealth umbrella, if you heard that, birds fly into my window, so that was a bird. So under our telehealth umbrella, we're having dramatic increases. We're actually approaching 1 million telehealth appointments. But telehealth, and this is something as a spoiler alert to keep in your mind, is that telehealth is both video appointments and phone appointments as well. So we were crossing kind of over that boundary in the last fiscal year. And on the right is looking at these video appointments. And so we were having this nice increase of both the number of appointments we're having and the number of veterans that were being seen. And so kind of just from the kind of fiscal year 18 to 2019, we had a 26% increase into the home and 169% kind of overall. So we were on this really nice trajectory pre-COVID. So the group, there's a group in the Bay Area that has been looking at, I think that is the YouTube. Hold on one second. Always commercials. I don't know if you guys remember when YouTube didn't have commercials. It was so nice. Oh, memories. Let's slide back to that talk. So this group out in San Francisco, basically they're the ones who, they got a chance to track these people who received the tablets that the VA issued out to find out kind of what was kind of driving their need to have this VA tablet. And it was the things that we were thinking, right? The travel time of how much time they're having to go to the hospital, come in, how much it costs to do that. So the way this chart looks is kind of blue and red means things are big problems or small problems. If it's green or towards the end, they don't consider it a big problem. So the kind of stuff on top, travel time, cost of travel, kind of physical health conditions that might be getting in their way to come in for care. These were the kind of the typical barriers that we thought were there that the tablets were helping to address. And so in the Charleston VA specifically, before March of this year, most of our telehealth appointments for mental health were being conducted either by the PTSD clinic that I'm part of, or we have a special telemental health clinic. We have two separate clinics for reasons that are convoluted and very governmenty, but we have two clinics that can do this, that have a mix of psychologists, psychiatrists, social workers, and then our trainees are both psych interns and psych residents. And in the PTSD clinic, about 60% of our caseload was telehealth. And then in this telehealth clinic, 100% of their caseload was telehealth by definition. At least that was named well. So I got a research development award back in 2018 with the goals of trying to find ways that we could kind of increase how we can implement this telehealth, particularly for PTSD, because that was my wheelhouse, and so that's where I was sticking. And I wanted to look at our national data to understand kind of how it was looking compared to in-person and how Ben spoke, look at the effectiveness of it with kind of the economic impact, doing a budget impact analysis, and kind of what I find the most important, and the stuff that I'm going to present some data on here, is looking at these qualitative interviews, both with veterans who are engaging in care this way and the providers who are delivering it, to understand kind of how satisfied people were with it. And it wasn't surprising. The veterans just loved it. You know, they felt like they couldn't have done treatment without doing, you know, having it set up this way. They hate parking at the VA, which I get. We all hate parking at big institutions. Unless things have dramatically changed, parking at UCSD, I think. So I was there for 5 years. I had less than 5 parking tickets, but not that much less. And it really, you know, was helping get them into care that they needed, but it was a very biased sample. I was talking to people who had already drank the Kool-Aid and signed up to do care this way. Talking to people who are declining it is also really important and something that we need to be doing in some of this work. The providers were doing the requirements. So starting in 2018, the VA created this push where they wanted every provider to have at least done one, this is what life was like in 2018, at least do one appointment through telehealth so you can get counted towards this. And so over that year, we went from 15% of the providers having done it. So basically this, you know, the 15% down here was the PTSD clinic and the telehealth clinic. And by the end of that year, we got 85% of the staff to have met that requirement. They did the one appointment they needed to have done. But it really wasn't easy. We had a ton of administrative and clinical challenges, you know, for coding and billing purposes, you know, all of this beautiful healthcare data that we all love to be able to access. We spend so much time trying to build the data in a way that we can then play with it afterwards that I think we don't think about the design of what it's requiring to even set that up on the front end. So it was adding a massive amount of time for providers. They're trying to, you know, be able to kind of create this new system, put people into slots that they belong in, have their assistants make sure that's not an in-person appointment, it's a telehealth appointment. And then they need to be able to actually deal with the technology of, you know, when the link doesn't work, when the veteran hasn't charged the iPad, when they don't remember the password to get into their email account. And providers at the same time, we had this huge push for access to care. Providers' caseloads are very, very, very full. And so adding one extra thing on top of it was a huge burden. And when I talked to providers in particular about doing care this way, we had a number of concerns that were coming up. The first one was definitely related to emergency procedures. So they were worried about being able to send out rescue to suicidal patients. You know, one provider said, my ability to rest my head on my pillow at night is compromised in a crisis on VBC more so than in person. Even talking about it right now, you know, primarily just want to make sure everyone is safe. In these situations, I think the clinic is a better environment. At least I feel like you have more control. So kind of having concerns about that safety and kind of related to that, this concept of a high-risk patient, which that's kind of a topic for an entirely another talk, but being asked to treat patients that they are worried aren't actually appropriate for this, maybe actively suicidal, have severe alcohol use disorders, or actively psychotic. A provider was talking about just wanting to be able to smell her patients, that when you're in person and someone shows up drunk, you can smell it pretty quickly, and you might miss some of those cues if you're doing care via telehealth. Another concern was veterans not taking appointments seriously. You know, our kind of worst offender, the most recent one that's sticking out in my mind is an intake appointment where the veteran answered in the bathroom, on the toilet, absolutely using it. And the provider needed a little bit of decompression after that, and something that you never used to have to talk about when they were coming into your office. And then the other issues that were coming up were related to technology impacting care when the systems go down, and having a tough time just dealing with, you know, whether it's the scheduling system, the veterans Wi-Fi, if they're way far out and remote, kind of all of those type of issues. And then issues in the system that are making it difficult to engage in some evidence-based care. So as psychologists, we can't give a blood test and see kind of what levels are looking like. We primarily give self-report measures. And if we don't have a system, which we're slowly trying to work on now, but if we don't have a system to kind of administer those helpfully, that becomes part of your clinical session and cuts into the active care that you do. So I looked at these provider concerns and then was kind of curious if the clinical data was actually reflecting what they saw as happening. So this is kind of where this mixed method stuff comes in, right? So what I did is over a 6-month window, I had asked for telehealth issues to be tracked in session. I know this was not perfect because, again, I'm now asking for an additional thing to be done on top of everything else already doing. But out of the kind of appointments that I was alerted to, basically 90% of them were technical issues and about 10% were these etiquette ones. That's what I politely refer to as like answering sessions while driving, kids present, drinking, other issues. But of those technical problems, about half of them were signal problems. A third were the network being down. When I was doing this, I don't know what was going on, but we were having a lot of issues on our side, and it went, we just, the veteran had access, great connection, but we just couldn't get it connected on our side. And only about 17% were actually veteran user error. And then I asked the providers to kind of rate the quality, and they definitely felt like when sessions were impacted, they were dramatically impacted. That 40% of the session was being spent kind of not doing therapy, but they weren't actually calling the telehealth desk. So we have a 1-800 number, it's fully staffed, it covers all the hours. They're very nice people who answer the phone. But I think for all of us, I know for myself, just for other issues, I dread calling a help desk because I don't know how long it's going to take and what all the steps are going to be. So only about a quarter of these issues with problems, the help desk got contacted with. So it was interesting that basically the one providers were the most concerned about and coming up consistently were the things that were less likely to occur. That was really some of these tech issues and other problems that were much more frequent, but didn't really stick out in providers' minds. And so I was like gearing all up, and I was going to kind of work on my next proposal. And then the world kind of lit itself on fire and kind of impacted telehealth care a little bit. So at first, the few people I've met with today, I was pretty concerned that my entire kind of research track was going to have to change, because my whole goal was to, increase the amount of people using telehealth care. And now we have a global pandemic, so everyone's just going to use it, and now we're done, right? So spoiler alert, no, we're not done. There's actually plenty of work still to be done. So in the VA, I've been teleworking for the last year. I was the exception to the rule. And so really, the nice thing is at our particular location, the telehealth team was 100% telework. They were a model that could really be based on. The tough thing about that model, though, is they all had government furnished equipment, which I also have, which you wouldn't think getting a laptop from the VA is all that great, but when you need to get connected into the network and you have the direct path in, it makes a world of difference. Basically, everyone else that got sent home got to go in through the VPN route, figure out how to get home offices set up, deal with kind of what everyone in the world has to deal with. What does it look like at home? Are you set up? Do you have beagles that have allergies that sneeze through things? Do you have kids at home? Like all of these things all of a sudden now got impacted. So we spent a couple weeks trying to figure out what it was looking like. And because I'm a nerd, I then wanted to see how it went, right? So the providers did so well. They kept doing this treatment because the veterans wanted to continue. I think it would have been very justified to be like, okay, global pandemic, all of us are, life is changing right now. We're just going to pause this care. But 75% of them didn't. They kept going and kept doing it. And on the veteran side, a lot of the veterans kind of described themselves as being in combat mode, that they had really been prepared for this, right? Like they were very vindicated. They had everything they knew, and they knew that avoiding people and getting, not being in crowds and not, basically everything that we've all been now focused on doing the last 6 months, they're experts in it. They could be leading seminars on how to avoid. And so they were fine. They were like, let's just keep going. It was the providers who were having a much tougher time adjusting to doing this treatment remotely while with the chaos kind of going on in their own homes. And for the veterans, so I had mentioned before in our PTSD clinic, before COVID, about 60% of it was done telehealth, 40% was in person. So I was really curious about what happened to that 40% who wanted their care in person before the pandemic. So I went in and grabbed all of those people who were kind of scheduled for things before we kind of got this mandate to shift everybody to remote. So that happened in March. And I tracked them through July. So starting in July, the VA in Charleston started allowing some in-person appointments. So I could see kind of what happened with these people. About 75% of them made the switch and kept going in care. We had 11% that dropped out, though I grabbed people who were both kind of regularly scheduled and new patients. So some of those people were kind of brand new, didn't engage in care at all. Some decided they were feeling a lot better. I think because all of a sudden now the world was kind of living PTSD life, and so they didn't feel like they needed care anymore. About 9% only wanted or engaged in phone appointments. So they just did it over the phone, not through tele. And we only had 5% who waited and they came back. When we opened the doors back up in July, they showed back up and kept going, which is interesting. So I think we're a pretty different clinic. I'm writing this up now and I'm pulling data to compare with some of the other clinics we have on site, because we were doing 60% of this already. Our clinic had drank the Kool-Aid. We, I think, looked different from a clinic that was 100% in person and had to make this switch. So I'm trying to pull some of that comparison data now, because I suspect it does not look like this, but I thought was pretty impressive. So compared to the VA as a whole, this really busy graph that I swiped, it shows a couple of important things. So I mentioned that spoiler before. So kind of down this like red line in the middle, that's face-to-face care. So we can see when the pandemic hit, right? Like we're doing great, we're seeing millions of people, and then zoop, right down. Now we can't see people in person. And then, but the cool thing is this orange line, yellow line, whatever color that is on top, that's our workload. So we're still seeing people. Patients are still getting their appointments being done. So how are they doing it? So this kind of green line here at the bottom, that's the video telehealth. And it's a dramatic increase, right? From February to March, but it's not this blue line. So this blue line here is telephone appointments. So when I thought that everyone was just gonna switch over and do video care, I was wrong. The default has really been, okay, then I'll just call you over the phone. Which means I still have grants to write, which is a good thing, right? So we have a couple new projects that we're looking at. This one, Dr. Moreland is a part of, and I'm so excited about. So this is a project to really try and understand what are those barriers and facilitators that are impacting places that did a great job adopting telehealth care and the sites that really didn't do a great job. So basically, we're gonna pull out kind of 5 facilities that have really been doing a ton of telehealth care and use kind of a range of like the big facilities, medium, the smaller facilities, and then match them basically with these low facilities that just haven't really picked it up in comparison, and do interviews. And we're gonna talk to leadership at these sites. We're gonna talk to providers who've been doing a ton of telehealth, and then providers who really are on the lower end. And I'm really interested in the providers who are kind of mixed at each of these facilities, right? So if you're at a high facility or high use facility, right? So in Charleston, we do a ton of VA Video Connect, lots of telehealth, and we absolutely have providers that refuse to do it. So I am very curious to talk to them to figure out kind of what's happening, you know, what is wrong with the stuff that we've designed that is preventing them from doing this thing. Because if you aren't gonna do it during a global pandemic, you're definitely not gonna do it afterwards if we don't figure out what's going on. And then I'm really excited to talk to these high use providers in these facilities that no one else is really doing it all that much, but they're championing it and out there and doing it. So we can kind of get some ideas of kind of how were they able to overcome these barriers and figure it out. And then we're gonna survey providers at all these sites too, because we can't interview everyone everywhere, but I'd love to at least get a little bit of data to find out kind of what's going on there, and then integrate all of this to find out, where are these pockets and how do we, when I first started doing this and was writing that grant a few years ago, I really thought a lot of it was on the veteran side, honestly. I thought we weren't like hitting them right, we weren't marketing it correctly, maybe the devices we were sending weren't quite what they wanted. But now it's like, oh, there are 2 users, right? Like the provider side is very, very important. And there are things that we need to do to be able to address design for them. So that is one of the newer projects. The other one I think is really cool too. So there were particular laws. So kind of at the height of the kind of opioid pill mill epidemic back in 2018, there was this law that was enacted where you have to see a patient in person for your first appointment, and then subsequently every 2 years if you're prescribing any controlled substances. And this was put in place because literally back then you could go online and try and get a prescription for an opioid, never see a provider, and then you'd have it. Ta-da! That didn't go great. So between, from 2008 to now, life looks a lot different. Telehealth is really different. So they've waived this act with the kind of declaration of an emergency in March of this year. They've dropped this. But I don't think the providers necessarily have dropped it. There's a lot of hesitation and concern about prescribing these things without seeing someone in person without getting UDSs. So basically I'm gonna look nationally and kind of track what our prescription rates look like And if they stay the same, telehealth saved the day, right? Like we were able to maintain care, providers got what they needed. It was great. If our prescription rates go crazy, go through the roof, we need this law. This is a problem, we can't trust people. But if they drop dramatically, which I suspect they will, we need to understand kind of what was preventing providers. Like legally they could do it, but they still were concerned, how do we address that and still make sure that people are getting the care that they need. So after the pandemic, there's going to be an after. The VA has the goal that 30 to 50% of our mental health care is still going to be done on an outpatient basis via telehealth. We haven't hit that now. So we need to figure out how do we actually get up to that number and what are those barriers that are kind of keeping us from it. We don't really know a lot about treatment preferences. I suspect that, it's not that providers are saying, do you want to do a video appointment or do you want to do a phone appointment? I think they're just saying, I'm going to call you over the phone, that's easier. And that's what's happening. There's not actually shared decision-making that's going on there. And then there are going to be a few new projects kind of coming down the line, maybe incorporating the use of peer support specialists, which are kind of former patients that got really, a lot of benefit out of treatment and now could kind of link that care and have both the user experience on the veteran side and the provider experience to help make some of those connections. And then also working with the community to kind of incorporate more telehealth. We're really spoiled on the VA side. So we're trying to kind of continue to spread this out and see kind of how we can do some of these things out in the community in Charleston. So that's kind of the spiel, the full rundown of everything.
Awesome. Thanks so much. You totally didn't, you said you were going to have told me everything during 101. I thought, no, but this was great. I think we'd open, for questions. Is there any questions already posted into the, no, I don't see any. All right, don't be shy.
I'm not scary, and I like to talk.
All right, I'll get the juices flowing. So obviously, you kind of brought up one of the real strong points about the VA system, right? Which is it's federal. It's kind of like the whole country is on it, right? And so you can have these kind of specialized places that you then call out. How would you imagine this being replicated by different kinds of systems that are much more kind of, I guess, broken, shall we say, but segregated?
So we're definitely not the only people who are doing this. Basically, everyone is kind of done this to some extent or not, especially recently. So on the MUSC side, they have a consortium throughout South Carolina. MUSC has multiple hospitals, so they're doing different versions of this. I think the tough thing is trying to make sure, we have the privilege of kind of all of our notes connect to each other. We have the one device that's sent out, so we know it's all the same thing. So I think there is concern and kind of question when it's like, okay, you're on one system and you're trying to link to one device and you have different projects and piecemeal, but I think that's kind of a question of how even just to get it kind of going just in the healthcare system overall. I know for me, where I'm at, there's a big healthcare group called Dignity Health. And so I try and just keep my appointments there, not because my healthcare would cover anywhere, but I know it'd be easier if I just kind of went to the same place. So I know that doesn't answer your question. I don't really know the best way to do it on a systematic level, but we're definitely not the only people doing telehealth. My dog is pacing. I think I had put the dog door down so he doesn't bark. I'm going to open it really quick and be right back. So then you guys can think of questions for me.
Fantastic. Oh, I think we got questions. So the first question from Chen Chen is, how do you think about the paradigm of integrating telehealth into mobile platform? In particular, recent mobile devices are equipping fancy and magic sensors, etc., like the LiDAR in latest iPhone 12. These days, the telehealth service in EHR, like MyChart, does not seem so good. Sadly.
Yeah, so it's interesting. So the VA hasn't really, up until very recently, spent much time integrating outside apps that we just keep developing on our own. And so we actually, I can't remember the count at this point, it's at least a dozen of our own apps that theoretically do integrate to kind of at least gather some data that way to be able to kind of link to the chart. I think the biggest issue with kind of mobile devices in general, I think there are a number of issues, but I think the biggest one, at least that kind of is on my forefront is honestly the data privacy issue. So being able to, I think to link them correctly, you need to let the data flow freely, right? Like, so I've, you know, become a part of the Apple cult, and my watch and my phone and my computer, all my stuff is everywhere. And I also know they track all my stuff, and like, no, I can't hide because Apple knows like when I go to sleep, and they know what I eat, and, you know, all of those type of things. And so I think that's how they function best, because and I don't understand how they're actually designed, but I suspect a lot of it is based on a lot of data. And so in order to have them function correctly, you need access to a lot of protected data that we can't then ensure will safely get back into the chart. So I think that that's, you know, I think we have the option to do some really cool things with devices. We have a couple of studies in Charleston. So one of our biggest treatments is called prolonged exposure. And so we send people out to do, basically, you tell me what you're afraid of and I make you go do it. And so it sounds terrible. And what we're trying to do is kind of use some devices to see, okay, how long are you staying? What did your heart rate look like? What did your skin conductance look like? Because we actually do want you to feel some anxiety, because the idea is you do some anxiety, you feel it, and you get to the other side and realize you can handle it. So there are kind of projects and kind of really cool possibilities. I just think a lot of the work needs to be done on how do you actually integrate it in a way that's useful for the providers and the veterans or the patients, and how do you do it in a way that, I mean, across the board, like for humans to change, we need to have good enough motivation, right? So I'm just not quite sure the pros of integrating some of that stuff are outweighing maybe some of the cons. We need to like hit this tipping point. At least that's kind of what I was thinking.
Okay, next question. Next question is from Eleanor Burgess. I interviewed individuals managing depression this summer as part of my dissertation research. We had a lot of trouble connecting via video for interviews. I wonder if the phone calls also help to adapt to poor Wi-Fi internet service environments. Also, I am curious to know if you feel that the video is substantially better as a therapeutic experience.
I was talking about this a little earlier too, because I totally get what you're saying, right? Like I think practicality wise makes complete sense. You know, our phone system has been around, I don't know when the phones were invented, but we've had it for a long time, right? Like we have kind of decent ways to connect with people over the phone. And I think it's not that everything can't be done over the phone. You know, if you're asking a survey item, if you're doing kind of some of those type of things, you know, I think it probably could be done. Even some medication management appointments, if your medications are working well and you're gonna have a 2-minute appointment with your psychiatrist, maybe it doesn't need to be over the video. But I think there are kind of two issues with doing it over the phone. There's probably more than that, but things that I can think of. First, we don't have any data to support that our treatments work that well. So we had spent, you know, the last 10, 15 years making sure that our treatments worked well in a video telehealth environment. And there's a lot of therapy that involves, especially with PTSD, there's a lot of avoidance. And so avoidance over the phone could be silence, or it could be that they're really thinking about what I'm saying. And I can see that if I can see your face. Like if you're just thinking about what I'm saying, but you're quiet, you're still engaged with me. But if you're on the phone, you could be thinking about what I said. You could be, you know, distracted by your dog who needs to go out. You could be distracted by the email that pops out. You could be purposefully trying to think about it. And I have a better way to gauge that when I can see you versus when I'm talking over the phone. So that's part of it. And then I also think there are a lot of safety concerns. You know, it's interesting when we proposed this idea of doing video telehealth, everyone's like, oh my God, but emergencies and crises, and you can't just walk them down to the ER. How are you going to ever do it? And those are all real concerns. And we have, you know, a lot of systems that are put in place to address those. But when you're over the phone, you can't actually see what's happening around you. So if I see a veteran and they're disheveled and where they're at it looks terrible, or they're outside and kind of huddled and trying to get away from potential, you know, we can have the possibility of seeing some domestic violence things going on. I get probably a better clue of kind of the cleanliness of their home. Like I might actually have a better idea of what their mini mental state is like when I can see them. Over the phone, I just don't think I'm going to get that. So I use the telephone, I schedule it. If something happens and goes wrong, I'll go to it, but it is not something that I would ever feel as a sufficient backup. I'm not sure if we're ever going to have good enough studies to put those two head to head, because no one really predicted this particular outcome. We kind of just thought we were going to skip the phone. But that's kind of at least where I'm coming from on the telephone front.
Hi, Ursula. Thank you so much for your talk. So I'm working on doing some social signal processing, kind of doing multimodal analysis of face-to-face kinds of interactions with physicians and patients. And we're kind of trying to take some of that social signal processing into the telehealth venue as well. And I'm wondering, how do you think that the telehealth compares to the kinds of research that you guys are doing for telemental health? Are they very similar, do you think, in the same kinds of issues that you're having? I don't know. So what are your thoughts about telehealth versus telemental health?
I guess I'm not totally sure how, like, so I basically live in telemental health land. Like, that's primarily like the stuff that I know. So I inevitably use them interchangeably, which is probably not appropriate. So I do think that we are much more advanced on the telemental health side because it was a pretty easy transition. Like, we didn't have devices. I can't give a blood read. I can't, all of, the vitals are not that vital to me. So I do think we have a much more robust literature. And I do suspect in the next 2 years, basically every type of other kind of healthcare is going to have some papers on it of what it was like doing their service that way. That being said, I do think, at least on the VA side, we have a decent kind of amount of literature. And I know there are some specialties that I don't know how they can actually get it done. But there are others, I mean, like teledermatology was so interesting. Like in theory, I was like, oh, well, you need to probably see the skin, right? But like, actually a lot of it is done through telehealth. Like, I guess I really underestimated how much of it was a visual type of assessment versus, I don't see oncology being done much via telehealth beyond like follow-up appointments. But I do, and I guess my view on just telehealth care in general too, is that I don't think it's the replacement for care. I just see it as like, we want it to be like a solid lane on the highway in. So we have people that weren't able to get in before that can use it. But I do think there are going to be some things that always should be done in person. And even on
hybrid models, really. Hybrid model, even for single patient physician relationship, it's going to be a hybrid model.
100%. So I'm remote. The last time I in theory, I'm agreed to be in Charleston every quarter and then pandemic. But when I was back there in February, I had a couple patients that were like, oh, you're going to be in town. I'd love to see you. And so we saw each other in person, and I normally see them through telehealth. I don't think it was any different. One brought me like a little banana bread from his wife, so that was nice. I don't get any patient presents anymore. But I think, there are some people, if you have social anxiety and you don't want to leave your house because of your disorder, I probably want you to come to the appointment and at the hospital. I want you to come in, and that's kind of going to be part of our exposure work. I don't, I could start telehealth, but I don't want you to stay in your house the whole time because that's going to be counterproductive too.
Right. Great. Thank you, Ursula.
For sure.
I'm sorry. If
You're
nobody else is going to ask questions, I'm going to totally take this time. So one of the things that I keep thinking about is privacy, right? So you brought it up a little bit, and the conversations that I've had with a few physicians, it's been a very small, just getting started thinking about some of these issues, is that some of their patients have a lot of difficulty with privacy because they have kids at home or just exactly what you said. And so one of the things that I thought was really powerful about what you were talking about is that being able to take the phone or the pad that you give so people can take their things from a vehicle. And I just thought that was really interesting.
And it's so interesting because like on paper, I don't think I would have originally been like, oh yeah, I would rather do a session with someone in their car. But it's been so helpful. I mean, it really it depends on the setting, and it's definitely not perfect, especially, in the summer, they have to run their engine, otherwise they will die in there. But there are, and especially for some of my patients that are really rural and don't have any cell phone capability, they can drive their car and sit in a Walmart parking lot and we can do our appointment, where I don't know if I could have convinced them to do regular appointments that way otherwise. So there are plenty of times, someone I saw at 4 o'clock yesterday, his family was all home, so he just sat in the driveway. It was just easier, he didn't go anywhere, but he knew he was going to have the privacy he needed to talk about this stuff. I mean, because, there's, I can get a whole soapbox about, how mental health is really just physical health, and, we shouldn't have the same type of barriers or concerns. But at the end of the day, we do want to have those private appointments to let yourself really go there and talk about the things that are the worst things you've ever been through in your life. So you need to have privacy. It's not optional.
Thank you.
For sure.
Yeah, thank you very much. This was awesome. It was a great talk. I really enjoyed it.
Awesome. I'm glad. It was really cool getting to talk. I spent so much time in VA land talking to other mental health providers, so it was really nice to talk to other people.
Great. Yeah, no, I hope, and, for those who are still on here, anyone who, wants to reach out, I guess if you don't have her contact, you can always reach out to me, and then I can give you contact.
Yeah.
Ursula, I'm going to reach out to you and maybe set up a meeting with Nadir Weibel, who's the PI on the project that I'm working on, because I think it would be really interesting to chat with you a little bit if you have some time. So
100%. I would love that. That'd be great. Awesome.
Thank you so much.
For sure. You guys have a good night.
All righty. Thank you.